Sir, you can start, please.
Shivang, great area. So just wanted to check if I'm clearly audible and also visible.
Yes, sir. Perfectly fine, sir.
Great. Thank you so much for confirming. Really appreciate, Shivang.
Thank you, sir.
And I'm just doing some housekeeping and then probably maybe just another couple of minutes and then I can see Dr. Praveen is very much available. Thank you so much, Dr. Praveen, for sparing your time. I really appreciate. And,
thank you, sir. Pleasure talking to you. And it's been really, I take this moment to disseminate the information about what we have done on Itolizumab to save lives. Thank you, sir. Thanks for inviting me for this lecture.
Pleasures are all ours, Dr. Praveen. Thank you so much. We are just going to start in another couple of minutes.
Sure.
Yeah, please. So I can see that President of Haryana branches, Dr. Sriniket Mishra has definitely joined in. And very good evening, Dr. Mishra. Dr. Sandeep Sharma has joined in as Secretary of IUH. Thank you so much, Dr. Sharma, for joining in. Really appreciate. Dr. Siva, I really appreciate you spending your time. Thank you so much. And many thanks to all the attendees as well for sparing their time. Well, so without any further delay, taking ahead proceedings of the day. A very good evening, everyone. I'm Dr. Pavan K. Gupta, Member Executive Committee, Association of Environmental and Occupational Health, Delhi, and Secretary of Association of Environmental and Occupational Health, Haryana branch. On behalf of Haryana branch, I extend a very warm welcome to the esteemed speaker, to the panelists, to attendees, and above all, to key stakeholders and the office bearers. I really appreciate you all sparing your time over weekend and joining in for this session. Gratitude and thanks to all of you. It is definitely a matter of great pleasure and privilege getting an opportunity to host such educational sessions and definitely contributing for the same. I'm really thankful to the branch and to the committee for giving me the opportunity. We all must appreciate the efforts of Secretariat as well, who has been keen and has been continuously engaged in disseminating the information about the seminar and also doing all the homework that was required to put everything together, and then we are able to deliberate on an important subject matter today. As we have seen that these are definitely trying times, but yes, Secretariat has been up and making all the efforts. As always, we definitely have a great speaker with us today. And before we go into more deliberation, it is the first event being organized on the platform of Haryana branch, and also a continuous endeavor and effort on the platform of DG Connect webinar series. That is an ongoing event. We will definitely I will be introducing to our esteemed speaker, and we have just one session today, and Dr. Praveen R from Biocon Biologics is with us to deliberate on the subject matter, and the topic is Itolizumab, optimizing better outcomes in COVID management, and very, very important and apt in current times. And I could see that our former president, Dr. Shyam Pingle, has joined in. Very warm welcome to you, sir, on behalf of the society. And very warm welcome to Dr. Rajiv Kumar Jain, sir, Vice President of Senior Vice President of Delhi branch. Thank you so much for spending your time. And we have Dr. Ashish Vijay Jain as well with us, Vice President of IUH Delhi branch. I really appreciate you all sparing time and joining us this fine evening. So, as we're proceeding ahead, I requesting support of our president of the branch, Dr. Shiniket Mishra, so to please give inaugural address and declare the webinar open and declare this e-platform open for further deliberation. So over to Dr. Shiniket Mishra, please.
Thank you, Dr. Pawan.
Thank you so much.
For a very good introduction of everyone. Welcome all the delegates of this inaugural session of AOEH Haryana. And I'm very happy that this is our first event after the formation of new branch. I welcome Dr. Praveen for this inaugural session. I also like to thank Dr. Sandeep Sharma, Dr. Ashish Vijay Jain, Dr. Rajiv Jain for helping in the formation, and all the office bearers of the Delhi branch in helping in establishment of this Haryana branch. So I'm very much thankful to them. I welcome Dr. Shiva and Dr. Shyam Pingle as a senior member of Occupational IOH National Branch. We are happy that we are going to start our first event. So after formation of this branch last year, due to COVID, we couldn't have any activities. So now we are starting our activities. And Dr. Praveen and Dr. Pawan, we can start our session because the duration is very short. So I will not take much time and we should start this.
Thank you so much, Dr. Mishra, for that very, very warm welcome to all our esteemed guests, and also thank you for giving a go ahead. And before proceeding and handing over this e-floor to Dr. Praveen, I would like to give an introduction of Dr. Praveen and on the top and about the topic as well on which he is going to deliberate. And once again, thanking all of you for sparing your time. So a brief introduction. Once again, Dr. Praveen, I hope you are able to hear us very well, and also
Yes, sir.
we are visible. Thank you so much for confirming, Dr. Praveen. A brief introduction about our speaker of the day. Dr. Praveen R, a Senior Director, Medical Affairs, Biocon Biologics Limited. And he will be deliberating on the topic, as I have mentioned, Itolizumab, optimizing better outcomes in COVID management. Dr. Praveen develops and executes medical marketing strategies for the therapeutic area by closely working with different verticals and helps in understanding their need, updating them on given therapy, and organize continued medical education for healthcare practitioners, carrying out advisory boards, planning clinical research programs, and also publication strategy. He plays a key role in reviewing study or new launch proposals to make funding decisions to product pipeline expansion. His key experience goes as providing strategy development, planning and implementation, and oversight of clinical trial programs via ongoing collaboration with the Medical Affairs Group, developing scientific platforms and knowledge resource for portfolio products, oversee clinical peer review, monitor quality and appropriateness of medical care, a medical lead for the launch of new product and providing strategic input for the assigned therapy, contribute to pre-launch, launch and post-marketing medical strategies and plans for the product, develop and cultivate important relationship with internal and external stakeholders, KOLs, and definitely KBIs. Medical lead for the launch of new product and providing strategic input for the assigned therapy, as I mentioned. Contribute to pre-launch, launch, and post-marketing medical strategies and plans of that. So that, with that, once again, thanks to you, Dr. Praveen, for spending your time, and I hand over this platform to you for further deliberation. Over to you, Dr. Praveen.
Sure. Thank you very much. And thank you very much for the kind words, Dr. Pavan. It was really a pleasure interacting in this platform. And I am happy and I am pleasure to share this kind of knowledge to the fellow colleagues of ours. And so that we can actually, considering the pandemic, what is hitting us, we have been doing, and I think that we can do justice to what we are up to. That's the point which I wanted to put it across. I would like to also thank Dr. Mishra for giving me this opportunity. Thank you, sir. Dr. Sandeep Sharma, thank you very much. And then Dr. Sham Pinge for getting this opportunity, and Dr. Shiva. So, and Dr. Sandeep Kumar. So I think so with that, I shall start sharing my slide. Possibly my voice is clear, or you want me to increase my audio level, or it's okay?
This fine. We can hear you very clearly. Thank you so much. And yes.
Yes, super. Thank you. Just give me a second. Let me share my screen. I hope my screen is visible.
Yes, we can.
Yeah, thank you. So just giving you a small preamble for what we are up to is. So I staggered my what you say the lecture or the talk for the next 15 to 20 minutes or max 25 minutes about what is this drug and what is the experience that we have gained with this drug, and what is we are doing currently with this particular drug or the molecule, and what is the future. That is what we're looking out for. So I will actually take you through the couple of things around it. So when we actually see the COVID aspect, where currently when I actually pulled out the data, in fact, I pulled this data today or this day evening, where we could see that almost what you say 30 to 3 crores has been what you say the infection that has been caused by the coronavirus. Out of that, what we have is something around 4 lakhs is the mortality what has been captured or documented. Let me use it again. That's been documented in the official website. So this actually talked about where you could see either at the level of what you say the new cases or at the level of the mortality. The second wave actually thought many things or thought a lot many things compared to the first wave. And I am not so sure or not so sure whether we are in the fag end of the second curve, or are we in the initial curve of the third wave, which I'm not so sure about it. But yes, this is the data what I am presenting it. So now stating all these things, and we have a good experience about what you say Alzumab, that is nothing but Itolizumab. So this actually what is come up with a lyophilized powder. So each vial has got 100 milligram of the drug, and this drug has to begin by intravenous administration. So now, where is this drug indicated? Let me be clear in telling that to the colleagues. It is used for a treatment of cytokine release syndrome in moderate to severe ARDS due to COVID-19. So that is the point where this drug has been approved, and this is the place where the physician clearly intervene when he sees that where there is cytokine release syndrome or cytokine release burst is happening. Then when you give the drug, then this actually makes a good revival or comeback to the patient's life. That is important. So now, as I told you, this is as available as a 100 milligram vial, and this is something like which I just need another minute. What is the dosage? So we always we recommend that 1.6 milligram per kg body weight to be given in the first dose, and then you wait for 7 days, and then see as per the physician discretion whether it is a rise in the markers or whether it is a decrease in the what you say the saturation. Then the physician can take a call on this after 7th day, stating that you can go for one more dose. That is nothing but half of what the first dose is all up to. So stating this, the question will arise. Do you mean to say, Dr. Praveen, that all the patients would need what you say, the two doses? No, it is not. Almost 80 to 90% of the patients would need only one dose. The remaining 10 to 15% or max to max 20% of the patients would need a second dose. That is after 7th day. That's the point which I would like to put across. So now stating this as a brief product overview. So now I'm just getting into the pathophysiology. Might be I would like to dwell another a minute or two in this particular aspect. And by this time, we know what is SARS, the coronavirus, and how does it actually bind, and then what does it actually give. Let me not get there, but what I would like to portray or what I would like to present to the team is that we know the spike protein of the SARS, the coronavirus. When actually what happens is that the coronavirus goes into the epithelial cells or the various cells like alveolar cells, where through the angiotensin converting enzyme 2 receptor, and then it gets into the cell. And during the due course of time, it actually what you say starts binding to the T effector cells. This is the major pathology which is responsible for the cytokines to come out. So let me put it across where you could see that where the this is a CD6 receptor. What you are seeing on the T cell is the CD6 receptor, the three pink colored dots continuous line. What you are seeing is nothing but the CD6 receptor, which is the T effector cells. So by what you say, the antigen presenting cell along with the virus attaches to the CD6 of the T cells. The moment it binds to the CD6, then where by various mechanisms, I will tell you a couple of in a very simplistic way, the various mechanisms where the interleukins, the TNF alpha, the various interleukins, cytokines, etc., getting poured into the system. So what happens? So ideally, this actually plays a very progressive or very good role. But moment actually when it has been in surplus, then this actually have a deteriorating effect on the human cell, depending upon the various organs. When it is a certain limit, it actually helps for the body to do this kind of immunomodulation. When the cytokines becomes too high in a number or too large in the system, then this causes a destruction of the various cells. Ultimately patients get into the various complications like MIV, mechanical invasive ventilation, the multi-organ dysfunction, and then into the death. So that's how the entire process has been looked into. Now I will just, as I told you, I am just trying to put it across. This is the antigen presenting cell which has got the virus laden, and as I told you, it is antigen presenting cell. So it actually binds to the T cell through ALCAM, and CD6 is one of the binding chain for that. So the moment it binds to the T cell, it actually activates the T1, T17 pathway and the T regulatory pathway. The moment when this pathway gets activated, then there is an increase in the formation or the synthesis of cytokines. But on the contrary, onto the right-hand side picture, what you are seeing it, after giving itolizumab, where the itolizumab blocks the CD6, it blocks the CD6, and actually it actually inhibit or reduces the proliferation or the cascade reaction of T1, T17 in the T regulatory pathway. Then there is a reduction in the cytokine which is being poured into the system. That's the point. So as I told you, when it is a limited quantity of cytokine, it is good. But over and above, it is actually deteriorating to the body. That's the point which I would like to drive it. So this is the same thing which in the various depiction what we have actually presented with. So now, understanding the mechanism, let me take you through the clinical aspects of what last 1 or 1.5 year or what we have actually generated in the clinical trial. Let me be clear and putting across. Question will arise in the physician mind. Dr. Praveen, is this the drug is new drug? The drug is not a new drug at all. The drug is being approved by DCGI or CDSCO in the year 2012 for a moderate to severe plaque psoriasis. That's clear. And we have traveled almost 8 years now with the patients, what you say, who are on getting treated for plaque psoriasis. We did the phase 3 trial. We got the approval in place. Understanding the mechanism of the drug, which we discussed about. In the COVID, what we tried doing is we actually we repurposed this drug into the in the what you say COVID management. So we did this trial, phase 2 trial with 30 patients, and then we got the approval from government CDS, or DCGI for restricted emergency use. That's the point which we got the approval. So as we went ahead, parallelly, we also did the trial in Cuba with the 68 patients, and there also we have got emergency use approval for COVID management. Both are phase 2 trial, which has been approved by the respective governments, either it is India or the Cuba perspective. As per the Indian government approval or DCGA approval, they clearly gave a notification stating that what study you have done is a phase 2, and then let's move, please submit a report by carrying it out a phase 4 data. Actually, this is, I would say that the 300 patient study is now completed. In fact, I would like to rectify this by stating we have completed data, the analysis is through, and the data is yet to get published, but the manuscript is ready for publication. That's the point. We actually traveled from 2012 to almost 2021 with various indications I will just try to do. On the parallel, what we are also trying to see is that this are all controlled clinical trial, what we have been generating. But when you see, there's something called as a real world evidence generation, which we have been doing day in and day out, which also the data which I will try to put it across. So this is something which we discussed so far. There are 3 trials of what we have done in COVID. Now, one is the phase 2, which we have actually done it from, which we got the approval. And then the other one is from the Cuba perspective. As I told you, the other one is ongoing with 300 patients again for the COVID management. But it is considering the mechanism of action, it does not stay only in COVID. We have a very huge population of what you say, the various disease profiles, starting from acute graft versus host disease to rheumatoid arthritis to what you say, even to the matter of lupus nephritis, and then to inflammatory bowel disease. Considering the mechanism of action, we are exploring all the other, what you say, the indication how the patients can get benefited because of this drug. That's where we are trying, and we are doing this across the globe. But yes, from the current discussion, I will just concentrate only on the few aspects of it. Most of us have asked, saying that yes, the drug, you got the approval, but let us know how do we correctly use this case. We all know the stage 1, stage 2, and stage 3 of the COVID, the journey which takes place through the early infection with the mild symptoms, that is fever, cough, etc. And the stage 2, where actually the patient moves into hypoxic or the shortness of breath, where he actually develop and what you say, the acute respiratory distress syndrome, and then he goes into what you say, the shock, cardiac failure, the etc. All that, the multi-organ failure, where when you actually intervene at the right time in the early course of the therapy, the patient's revival is better. I would say that is what we have witnessed, and that is what even backing up with the clinical trial evidence, what I'm going to show it to you. So with that, I'll take you through the phase 2 study, as we got the approval from government of India through this particular study, where, as I told you, there's a 2-arm study. One arm received the best of supportive care with Itolizumab. The other arm received only the best of care therapy as per their hospital protocol. It's a randomized open label study where we are analyzing the efficacy and safety of Itolizumab in COVID complications. So the number of patients whom we actually consider is around 30, the 2:1 randomization. 20 patients walked into the Itolizumab arm, and another 10 patients walked into the best of supportive care. And we have almost a span of 28 days as a treatment arm, which controlled, and then we actually end the study at around a month exactly, or 28 days to be precise. So what is the baseline population when you see it? Those who are hospitalized with what you say confirmed diagnosis of COVID, and with the saturation falling lesser than 94, and then with moderate to severe ERDS as per the PF ratio of lesser than 200 has been defined. So now the sites, what we have taken is 4 sites across what you say India, but to be frank, there are two places where we actually concentrated, considering the load. The two places where one the Nair Hospital at Mumbai, KEM from Mumbai, All India Institute from Delhi, and LNJP from Delhi. These are the 4 institutes where the recruitment actually took place, considering the initial first wave where the patient's load is all up to. So number of patients, as I told you, 20:10, and then where you could see that mean age is anywhere by around 49 years, with the preponderance of male being almost 1/3 of the 2/3 of the population is with the male population, and in both the in Italy arm, whereas both the arms to be precise, and the comorbid condition is especially on diabetes and hypertension. These are the 2 most common comorbid condition what we have seen in this particular group. So now, at the end of 28th day, where we could see that with respect to the 1-month mortality, there were no deaths that is seen in the Itolizumab arm, but there were 3 deaths that was seen in the standard of care arm, that is arm B. So obviously, yes, with that kind of ratio, we found it that the data is highly significant. So that's something which will be looked into. There might be eyebrows getting raised, stating that you did it with only 20 plus 10 patients, and there is no mortality. Yes, the study has been powered to talk about the efficacy in COVID, because safety we have already established in the last 7 to 8 years of the span of marketing the drug in the current the India perspective. Now, the other important aspect is that with a stable PaO2, the saturation without increasing the fraction of the inspired oxygen. So either it is in the 7, 14, and 21 and 30th day, you could see that after giving itolizumab, there is a rise in the percentage of patients having a stable saturation with 90%, 95, 100, and 100% of patients without increasing a fraction of inspired oxygen, where they have a sustained the saturation of the saturation of oxygen. But whereas in the case of the standard of arm control, where it is 60, 70, 70, and 70, that's a point which I would like to put across the standard of arm therapy. Now, that is one aspect of what you say the clinical or the oxygen. But what is the biochemical parameters? When you see it on the itolizumab arm with respect to the interleukin-6, one of the most common biomarkers in the currently that is being measured, within giving 24 hours of itolizumab, the curve shoots down or comes down significantly in the itolizumab arm, which is not in the case of the other arm, the arm B, the standard of arm or the standard of control arm. The same thing holds good for a tumor necrosis factor alpha, where it comes down in the itolizumab arm, but not in the case of what you say the standard of care or standard of control arm. So what is the result it talks about? Coming to the summary of the phase 2 data, the primary endpoint of 1-month mortality is statistically significant in the itolizumab arm, where there were no deaths in the itolizumab arm. The other factors like saturation, which is also sustainably improved, or the proportion of the patients improved in the itolizumab arm. The key markers like IL-6 or the TNF alpha actually improved or significantly reduced in the itolizumab arm. So that's where we actually concluded stating that itolizumab is a safe drug where in the COVID management, and it actually controls the hyperactivation of the immune system in the cytokine release syndrome. With that, this is the data what we had actually presented to DCGA, and we got the approval in place. Now, after submitting this data, DCGA gave the approval, and then what we tried doing is that we also have a parallel study which has been done from Cuba. So almost 76 patients who have been looked into either critically ill, severely ill, or moderately ill, either with in ICU with invasive mechanical ventilation, without ventilation, and then with outside ICU, but with significant comorbid conditions. So what is the point which I wanted to stress is that most of them are geriatric, with almost most of them are having one or other comorbid conditions, diabetes, hypertension, COPD, etc. All that. By giving itolizumab within a span of 72 hours, the critical and the severe group, almost 70% or three-fourths of the patients did not require an increase in the FiO2. And then what you say, the weaning started anywhere by around 8 days in the critical patients. And then the IL-6 reduced significantly within a span of 48 hours. So this is the clinical and the biochemical parameters what we have actually come across parallelly in the Cuban study. Then we got the approval from the Cuba perspective too. So as I told you, after we got the approval, we did the phase 4 study with a 300 population. Considering the number is quite high during that span of time. Let me actually, what you say, give you the inclusion criteria. There's nothing but those who are suffering from COVID with a saturation of less than 94, and then where they categorized the acute respiratory distress syndrome to lesser than 200, because 200 to 100 is moderate and less than 100 is severe. So on that inclusion criteria, where it's a single arm study, where we actually did the study across India with the best of supportive care from the respective hospitals plus itolizumab, and then with what you say, almost 28 days of what you say the study treatment. And we actually did also a follow-up almost 3 months after giving itolizumab, because there are a lot of post-COVID sequelae. We also want to understand that. So on that basis, like where if you could able to take you through, this is the baseline what you could see, that almost 80% of them is from the male population. And then where you could see that almost 15% is more than 70. If I could able to combine this 15 plus another 20, that is nothing but anywhere by around 37 to 44% of the population. They're actually more to a geriatric kind of population, where the PF ratio with what you say lesser than the severe category, or the PFR is around 23%, with 100 to 200 moderate categories anywhere by around 77%. This is what something to be looked into. I will take you through the various inflammatory markers in due course of time. So at the time of what you say, when the patient walked in, there were what you say the baseline mode of oxygen delivery is anywhere with respect to simple face mask is 42%. And then you can see how does it go with nasal prong or NIV or HFNC, all that. And they will also be given various other drugs, because it is unethical to do a study only with itolizumab but withdrawing other drugs. So as a process, like any other drugs, like as per their hospital standard of care, they are given antiviral like Favi, Rem, or oseltamivir, depending upon the various hospital protocols. Steroids being at that point of time, steroids were looked at in a very huge way, whether it is MPS or DEXA or hydro, depending upon the various hospitals. And then LMWH are apparent to be considered. And then various other antibiotics, which also includes hydroxychloroquine, has been given to this kind of patients. Now, I'm just giving you very broad level data, because this data is not being published, but yes, to the group where with the healthcare providers, this is very important to disseminate the information. Where with itolizumab, by giving itolizumab, the mortality is around 6.6, if I could round it up to 7%. So the recovery is anywhere by around 93% after giving itolizumab in patients that kind of what you say as moderate to severe ARDS in COVID. So that's something very, very promising or phenomenal outcome what we have actually come across with. Now, with the inflammatory markers, as I told, with respect to the PF ratio, so the PF ratio from what you say day 3 to day 7 and day 14 and day 21, you could see that it actually slowly weaned off. But yes, we could see it actually it's coming down to the normal, or what you say with more than 300 is what we found out. And that sustained up to from a span of 7 days to 14 days is what we actually found out. Now, coming to the other markers, biochemical markers, what we have seen is that the ferritin D dimer, you can see the baseline is around what you say, the mean is 651, which has come down to 374. whereas what you say, the other D dimers also has been coming down very drastically from the baseline to almost the day of discharge. So that's something which we have actually witnessed in this particular study. The same thing holds good even for CRP with almost with a mean of 53. It turned out on the day of discharge is nothing but 28 days with 14 is what the mean CRP with this kind of population. So that's something which actually reduces the significance of what you say the markers with respect to itolizumab. Now, just moving on to the other one, that is nothing but, as I told you, the real world which we have been generating, where we did something around what you say 1,600 patients across India. It's a very broad level that I'm just trying to put it across, where we have the patients who got discharged is around 1,450, and then the recovery percentage anywhere by around 9.1, and mortality is anywhere by around 9.2. This is done across India with various hospitals where our drug is being used, and then where we just took the mortality data from that kind of what you say through a digital application called as CalZ. So this data is already been analyzed, and we are yet to publish this, and the manuscript is in preparation mode. So coming back to the point, yes, the drug is being used in multiple clinical trials. Only thing which I would like to put a point here is that we have seen what you say the infusion-based reactions. Being a monoclonal antibody, the moment you give the drug, it actually sensitizes the body with the monoclonal antibodies, where the patient might have chills and rigors. But when you actually sustain the dosing span for almost 4 to 6 hours with a duration of what you say the IV infusion, then the adverse the infusion related reactions can come down drastically. That's something which we have learned in the phase 2 study. And then we have got a good what you say post-marketing experience, where more than almost what you say the 30,000 patients, or I would not say 30,000, but 27,000 patients have been treated or dosed with what you say with the itolizumab, or the patients have been dosed with itolizumab with the good outcomes. So now there are other drugs which I thought I can actually have this. There's other drug also in the market is interleukin 6 receptor blocker, which is already there. So what is the difference between itolizumab and then anti-IL-6, the interleukin 6 receptor? So itolizumab, as I told you, blocks by binding to the CD6 receptor, but whereas by the name itself, the tocilizumab blocks by binding to the interleukin 6 receptor. And then it yes, there is, as I told you, it actually regulate the T cells. There is immunomodulation role that has been played by itolizumab, whereas in tocilizumab it actually blocks only the IL-6 receptor. There is no immunomodulation role that is played with tocilizumab. The other important aspect which I would like to put your attention is, as I told you, the drug works, itolizumab works by blocking the synthesis or the formation of interleukin 6, interleukin 2, or all the cytokines, which has been what you say looked into. But whereas in the other case, the drug block only what you say the binding of interleukin to the interleukin 6 receptor. So it acts only in one part of the downscale of it. But whereas the itolizumab works in the upstream or blocks multiple cytokines or multiple what you say the biomarkers. That's a point which I would like to stress you with, which has got a unique mechanism of action being developed from the India perspective. So coming to the conclusion of this is that we have seen the mortality benefit with itolizumab, and we have actually completed the phase 4 study, and the real world evidence study also we have completed, and we are in the verge of publication of what these two studies, where it actually shown reducing the mortality and morbidity. And also what you say, we have that experience of marketing this drug since last 7 to 8 years that we have been marketing this drug. And this drug helps to control the hyperactivation of the immune system in response to the COVID, in reducing the cytokine storm. That's what I would like to put it across. Thank you very much for your patient hearing. Might be we can open for the questions, Dr. Pavan. Yeah.
Yes, thank you so much, Dr. Praveen. That was quite elaborate and very latest, I would say. We have definitely a lot of questions from the attendees, and we can see hands going up. And first and foremost is definitely our very own Dr. Rajiv Jain, sir, Senior Vice President of AUHD from the Delhi branch of IUH. So without any ado, I would definitely move to Dr. Rajiv Jain, sir, for the question. And once again, I thank you, Dr. Praveen, for an excellent deliberation. Dr. Rajiv Jain, sir, please.
Thank you, Dr. Pawan.
Thank you, sir.
First of all, I must compliment Association of Environment and Occupational Health Haryana
Thank
to
you,
take
sir.
this initiative to start this webinar. I hope it will be a series, and I must compliment Dr. Srinikit Mishra and your entire team in AUH Haryana to have an ongoing academic platform, because without academic platform, environment and occupational health will not progress in our part of the country. And I believe this is a good initiative, and I must compliment Dr. Praveen R to be the speaker in the inaugural webinar today. Well, the question that I have for you
Thank you, sir.
is, this is not going to last forever. COVID-19 will not last forever, but this drug will last longer than we believe. So what are the other applications or uses or indications where it can be utilized at the moment? What is the current evidence?
Thank you. I would say that you are very right. Yes. What we have witnessed, the COVID, the first wave, second wave, or might be the from the mountains, the magnitude of the waves might come down to hill and to the etc., whatever it is. We already have the drug approved for moderate to severe, plaque psoriasis for the dermat aspect. So that indication that has been already running. And where the futuristic, where the studies or the clinical trials currently going with respect to what you say from the global perspective is that we did a study in rheumatoid arthritis, RA, the phase 2 study, and we got a promising data on this. That's one. And now we are actually going to the next phase 3 study. That's one. The other potential indications is something which we are looking at is that the ulcerative colitis, which we are actually looking forward. And we are writing a protocol to submit to the DCGI to carry out a phase 2 study, in fact, so that we are actually looking that particular aspect. That's the second one. The third one is that this particular drug, last month, we got that orphan disease status for graft versus host disease. So that's something which we have actually received from US perspective. That's something very interesting. So we are now trying to see how from India perspective, we can actually do a clinical trial and then we see the data coming out. Stating all that, if you see, as I told you, it is an intravenous infusion, all that. So we are also trying parallelly, considering we can make the best use of this particular molecule. We are also expanding our process or the strategy for a subcutaneous preparation so that it can be used as an outpatient regime rather than going for a admission or for monitoring on a hospital. That's something we are looking forward for it. So I hope I addressed to the points.
Yeah, very right. In fact, that is the reason I wanted to know more about the various routes of administration that it is being researched on. Subcutaneous route you mentioned, because unless the route of administration changes, its wider acceptance will be very limited. So what are the other options being exercised in the research perspective?
So you're bang on. Thanks for that. That is where I was just trying to do. As of now, the drug has been approved for intravenous. As I told you, we are also parallelly initiating a trial for subcutaneous, which I think in the approved indication is moderate to severe plaque psoriasis. So we are going to do that. These are the two things which we have come across, which we are exploring. Other things is not in the pipeline. Might be that would be too much to talk about in this current forum. Might be this is what I could able to put across to you.
All right, thank you. I understand your limitations. Thank you so much.
Thank
Thank
you,
you so
sir.
much. Yeah, Dr. Jan, for those good questions, and Dr. Praveen for taking those up. Moving on quickly to Dr. Shyam Pinglesa for his comments and suggestions. Dr. Pinglesa. Okay. Okay. Then, yes.
Thank you, Dr. Gupta. Pawan, I hope I'm audible to you.
Very well, sir. Very well. Thank you.
Thank you for a wonderful treatise, first of all, a good program, and the speech coming from the people who really make it and are conducting various trials. So this is the most recent information. We appreciate that.
Yes, sir.
But first of all, why I joined today's program was I'm very thrilled to see the new branch coming up and starting the activities. So Dr. Sriniket, Dr. Pawan, and all the team wish you all the best. And I'm sure you will do more and more programs.
Yes.
Any program that you now is good enough.
Yeah.
Because you have to get your bearings together, you have to get your people together, and you have to got thinking together. So that's why anything and any activity that you do will always be supported. Thank you so much. But as you progress, you can see what is exactly our need. There is no need to, this is the world of copy paste nowadays, but there is no need to do what others are doing. Think of what different you can do. Think of what your constituents need, what your members need, and try to satisfy that need. So you have all our best wishes and any support that you ever need. Thank you so much.
Really appreciate your kind gesture, sir. Thank you so much for your kind words. We definitely will take it ahead in whole spirit. Thank you. Quickly to Dr. Siva for his comments and suggestions.
Good evening, everybody.
Good evening, sir.
I hope you all can hear me.
Yes. We can, sir. We can. Very clear.
First of all, congratulations to Haryana.
Thank you so much, sir.
And I'm also a cricketer. And I believe that when the opening batsmen do well, future is very, very good.
Thanks to Dr.
So,
Praveen.
Excellent work. And thank you, Dr. Praveen.
Thank you, sir.
For the excellent presentation.
Thanks.
Wishing Haryana all the best. Thank you very much.
Thank you so much, sir. Thank you. Over to Dr. Sandeep Sharma, Secretary of Indian Association of Occupational Health.
Thank you, Dr. Pawan and Dr. Sriniket Mishra, and especially the guest of today's lecture, Dr. Praveen. So, first of all, let me congratulate the Haryana branch for their kick start today, and with Dr. Praveen, and it was really a very eye-opening lecture for every one of us. Dr. Praveen, actually, we are all industrial physicians, and although we are not in the main streamline of the treating the patients in these critical units where this particular injection is used, but still, as a industrial physician, we should be aware of what these molecules are and when they need to be used. Because we have seen in many of our patients especially during the second wave, and many of our relations also, that they were asking us about the effectiveness of this tocilizumab, whether we can give it, is it required, or what are the risks associated with it. And if we are not clear with the things, then it is difficult to give an opinion about a particular molecule. So your deliberations today, they were quite helpful to us because you have given a quite good comparison between itolizumab and tocilizumab and how they react and what are the advantages. Like itolizumab, it has got additional advantage of immunomodulation, and what are the indications when it is to be used, that you have clearly indicated, and the recovery rate of 93% and mortality of only of 6 to 7%, that is also good, because we have seen that with tocilizumab, there was a lot of like fear psychosis was there, whether it may work, it may not work, because many of the critical care specialists also, they were reluctant to give tocilizumab even to the patients who in whom it was really indicated. And finally they come to the COVID and ARDS. So your deliberations were really very good, and your conclusion that it effectively controls the hyperactivation of the immune system in response to COVID-19 virus and reduces the morbidity and mortality related to cytokine storm. That is it brings a clarity in our mind that yes, it can be used, and as you have further clarified that in long run, after even this COVID is over, this molecule can be used for various other prevalent diseases like rheumatoid arthritis, ulcerative colitis, or graft versus host disease, or even plaque psoriasis. And that other thing was also quite interesting, that instead of IV infusion for 5 to 6 hours, you are planning to get a subcutaneous trial also, so that at least the acceptance within the patient community for this, and doctors can also easily administer this particular medicine. So Dr. Pavan and Dr. Sriniket, this was a grand opening for the Haryana branch, and congratulations to you and Dr. Ashish Vijay Jain, and especially your Sandeep Kumar, and to all the doctors who are from Haryana branch, and we will take this journey forward. And I would like to thank Dr. Shiva also, because he only during his tenure as committee chairperson of the revival team of the IUH branches, he was the main person who motivated us to get this branch revived, and we all tried to do our best and handhold this branch, and we will continue hand holding. And Dr. Praveen, this is a association of about 3,000 doctors across India, and we are from different branches, and like Delhi has got about 250 members, other branches also have got same 300, 400, 500 members. So now this Haryana branch it was very active some few years back, but somehow due to change of guards and circumstances, and with new faces, it will again be in limelight. And I thank you very much for today's deliberations and the grand opening.
Thank you so much, sir. Really appreciate your kind gesture and the support that you have been extending throughout. It would not have had been possible. Dr. Praveen, definitely your presence with the new topic, new molecule, latest thing. And I kept wondering during the entire presentation, how come you landed up in Cuba out of all the world, the one place that you show the small island. But then that is a question in my mind, which I'll keep it for later, because there are so many people. There are questions by Dr. Damodar Lele. 3 questions here. Dr. Lele, I'll just come to you just a couple of more minutes, and then we are going to take Dr. Lele's queries. He has posted 3 questions, and Dr. Lele will be asking you the question. But before that, to Dr. Ashish Vijay Jain, and then to Dr. Tyagaraju. So Dr. Ashish Vijay Jain, please. I hope Dr. Ashish Vijay Jain can hear us. Okay. Maybe some challenge. So Dr. Tyagaraju, request your comments and suggestions, please. Thank you so much for joining in. You have been an inspiration and encouragement for all of us. So Dr. Tyagaraju, request you to please unmute and share your thoughts and also the question that you have for the speaker.
Dr. Pavan Kumar Gupta, my hearty congratulations to you. I just saw this one, your name and Sriniket, and it was the H was there, so I thought it is an Haryana branch. And congratulations, your man has won a gold medalist in a gold medal in Olympics, and in the sports, Haryana stands #1. And like that, I too wanted you to be number one in this knowledge and this academic works. And you have a very good guide by Dr. Sandeep Sharma and Dr. Hall Delhi branch is with you, and they will all guide you. They will all help you to do the best. And we hope that you will be the model for our IAOH. And thank you very much for giving me an opportunity to this one. And I will just Dr. Praveen is the second term. I think he is speaking on behalf of Biocon.
Yes.
He's a wonderful speaker. He's nicely presented this one with an academic and data also he has given. A very nice presentation. My congratulations to Dr. Praveen also.
Thank you.
Thank you so much. I really appreciate your kind gesture. Quickly moving on to the questions by Dr. Lele. Dr. Lele, you can unmute and please ask your questions. Yeah, Dr. Lele, you can hear us, right?
Yeah. Can you hear me?
Yes, very well. Please go ahead.
I will ask, there are three questions.
Please.
I will start with the last question first.
Sure.
Now, these 300 cases which were shown here, now you have used the doctors have used everything. Now, how do you say it is only because of Itolizumab?
Okay, I'll take that, sir. Let me answer that. So when we do a clinical trial, we always use supportive care as one of the the additional features to that. Because the moment when I draw a supportive care, I cannot do a trial only with Itolizumab and prove that there's a benefit or the risk or something like that. None of the ethics committee will approve this because this drug has been now getting into a COVID. So always we'll have that something called as supportive therapy, which includes what you say the favipiravir or hydroxychloroquine or steroids. So when we use both as a package, and we found that there is only what you say 6.6 or the 7% as a mortality, and whereas the 91 to 93% of them have recovered. That's the first point I would like to put across. Now the second point, to substantiate that particular information, if I go back to my the phase 2 data, what we have been doing, if you see that very clearly, we did a 2-arm study. One is with Itolizumab, the other one is without Itolizumab, one is supportive care. And we found that all the patients in the Itoli did not, none of the patients died, but all the patients actually recovered. But whereas those with standard of care arm, where they have been given steroids, they have been given with hydroxychloroquine, they have been given with what you say the other antiviral drugs, but there were 3 mortality that has been seen in the standard of care therapy. So that is something again adding superimposing to what study what we have done. That is second point. Third point, which I would like to put it across to you upfront, is that AIMS partner, it's independent. So AIMS partner did an individual study where we did not have any interference and where they did their own study, and what they also concluded is that there is a good amount of benefit is being offered with Itolizumab compared to the standard of arm care therapy. That is also what we have done. But the data is submitted to the publication, but it is still not come out. We're just waiting for the data to come out because it has been done individually. We do not have any interference either with the drug, nor with the funding, nor with any manpower support. They did a study entire individual. That is what the point we are trying to prove.
The second question is, what is the difference between Itolizumab and cocktail injection, which is being used these days?
Okay, so you know Itolizumab is a drug which could inhibit CD6 at the what you say the T cell, and thereby it prevents hyperinflammation. But whereas the cocktail drug of Roche or the Cipla is Imidinib, this drug works at binding to the spike protein of the virus or the COVID virus, the S protein. So you have a totally different what is a mechanism of action. That is something has been seen. So what does that bring out on the table is obviously yes, the drug Itolizumab to be used for cytokine release syndrome, but whereas Kesarivimab or the Imidinib, that is cocktail of the Roche or Cipla, to be used in not in the later part of the life, later part of the COVID disease, but much earlier. That is nothing but either it could be the milder or it could be at the time of exposure prophylaxis. These are the two major indication for the cocktail drug of what you say the currently available in the market.
When you started using this drug, now why did you choose it? I mean, when you talk of psoriasis, cytokine storm, these are different things. Now, was it just like use of what shall I say, drug like? I mean, anything that was tried, was it something like that?
No, okay.
Or was there any theory?
Yeah, there is a good amount of what you say the science behind it. Like when you see the pathology of the psoriasis, or when you see the pathology of cytokine release syndrome, that is in the level of COVID, where you see a lot of similarities, where it is all regulated by what you say the T cell, which plays a major role. The common connecting path is the T cell. In the T cell, we have CD6. So the moment when you inhibit the CD6, you see a good amount of benefit, whether it is at the level of psoriasis or at the level of COVID. The only difference is that the duration of the drug giving is different in both the regimes. In COVID, you give only 2 doses max to max. As I told you, so 80% of them need only a single dose. The next 50 to 20% need the 2-dose regime. But whereas in case of psoriasis, the therapy extends for almost 6 months, the therapy goes up to. So that's a duration, because being a dermatological, being a chronic disease, that kind of duration of the drug is required. So that is a bit different. But the common connecting point is your T cell. That is the science behind of entire aspect of psoriasis and also the COVID management.
Thank you very much. Thanks to you and to Dr. Praveen Gupta.
Thank you, sir. Thank you.
Thank you so much, Dr. Lele, for your inquisitiveness and the questions that you have asked. I really appreciate the involvement in the webinars and the scientific events. You always have come up with really good questions, and also that enlightens other attendees and panelists as well about different aspects of the subject. So I really appreciate your involvement, Dr. Lele. We have been observing since very long, and I thank you once again and for those good questions. With that, I think I mean, I do not have any question as such or raised hand as of now. And also, we have crossed over time as well. I wholeheartedly thank, definitely first and foremost, to our esteemed speaker, Dr. Praveen.
Thank you.
And then to all the esteemed panelists and wonderful attendees who have been with us all through this journey of an hour and few minutes. And we look forward to more engaging events and webinars in coming days. I really appreciate your support, all good words and wishes that you have showered upon us. It matters a lot, and it will take us a long way, and we'll keep contributing. With
Pavan, you also take opinion of Sandeep Kumar and Ashish Vijay Jain. They will,
So yes.
be helping you out in taking your journey forward.
I definitely, Dr. Sharma, I asked Dr. Jain, but I think he was not able to, probably there was some glitch. Dr. Jain, Dr. Ashish Vijay Jain, are you back?
Sandeep Kumar.
Yes.
Yeah, sir, I am part of Arana branch, sir.
Yeah. So I had a word with Sandeep, and he was very much enthusiastic. I saw that probably for the time being. He also, Sandeep, you will be a crucial support. Please share your
I will definitely.
Yes. Thank you so much for your continued support. Dr. Ashish Vijay Jain, in case you are able to hear us, final comments will be from your side then. There is some challenge, Dr. Sharma, I think.
Actually, he is on international call, like he told me.
Okay. So maybe. Yes.
So,
Fine then, sir. I think we will relieve the panelists and audience and attendees, and also Dr. Praveen for their time. So once again, thank you to all of you. We'll connect soon. Next week.
Sure.
Thank you.
Thank you, everyone.
Right. Thank you.
Thank you, sir. Thank you so much.
Thank you very much. Thank you.